Mamas. Dr. Boopathy.
Thank you for the opportunity, sir. So I will be presenting two cases. I don't have any conflict of interest regarding this particular presentation. It's a salvage PC in a post-COVID patient who had a recent cabbage and with a DKA. 46-year-old female, anterolateral MI, thrombolized elsewhere, had an angiogram done, showed a left dominant circulation, left main triple vessel disease. Cabbage done next month with 4 grafts. Background, she's a known diabetic hypertensive. She had COVID, recovered from COVID pneumonia 3 weeks before her ACS event. And now, this time she presented, she was apparently normal a day before. She came for a SVG harvest wound infection, which was never studied in all kind of cabbage PCA comparison studies, wound infections. Later, she developed chest pain, retrosternal compressive anginal type, heart failure, and presented to emergency department. These are all clinical parameters. She was in just entering into the phase of cardiogenic shock. Her LV showed a severe LV dysfunction. Also had RV dysfunction. Troponins were elevated. She was admitted in cardiac care. This is almost a month after CABG. The clinical status were same. ABG revealed a metabolic acidosis, pH of 7.2 with lactemia. Chest X-ray showed a pulmonary edema. She was managed initially with NIV. Inotropic support were initiated. Her sugars were sky high, 600s, and ketones were positive. There was anemia. She was transfused initially. 6 hours later, she had worsening of breathlessness, had a brady cardiac arrest, resuscitated, and then emergency coronary angiography was done. This is the emergency coronary angiography which was done after multiple attempts of CPR. You can appreciate the distal left main lesion extending into the calcified distal left main lesion extending into the circumflex. Lemma is patent, but is still not yet matured. All other 3 grafts SVGs are gone. So it's a kind of rescue bailout for the particular patient, and 1.75 burr was utilized to burr the distal left main and circumflex. She had an event during the procedure again, and we cut the lesion with Wolverine and stented the lesion with, then we again put a wire inside the LAD, opened the ostial LAD alone. There was a tight mid-LAD lesion. We presumed that the flow from the left main into LAD will not compromise the lemma maturity because there's a significant 95% lesion in the mid-LAD. The graft to diagonal is also gone. We stented the lesion from left main to circumflex and then recrossed, kissed, and then did pot. We thought of giving maximal benefit to the patient. We wired the diagonal also later, and then this is the repot, and then through that we wired the diagonal, just did a POBA, whatever benefit she can get, which let her get it. Then we ended up with this result. She had a very stormy course. She was on 4 inotropic support on day 1. On day 2, all kind of ischemia set in. Kidney shutdown, non-oliguric, ischemic hepatitis, elevated procalcitonin, anemia worsening, disseminated intravascular coagulation, DAC, stopped antiplatelets. However, her hemodynamics were gradually improving. Day 3, IVP and temporary were out. Worsening azotemia persisted. The SVG harvest site revealed pseudomonas. Antibiotic stepped down from meropenem, ticoplan to cefepime. Day 4, with doubtful things, we initiated on ticagrelor 60 mg only, all based on only gut feeling because we were playing with fire at that point of time. However, her hemodynamics started slowly improving, extubated to CPAP mode. However, there was sudden worsening of GCS and urgent brain MRI was done, which revealed multiple punctate infarcts. A new time bomb was observed in the form of invasive fungal sinusitis with no intracerebral invasion. Day 5, biopsy was done, which revealed mucormycosis and aspergillosis. Started on antifungals, including posaconazole. Again, stopped antiplatelets. Day 6, emergency endoscopic debridement was done. Showed both mucormycosis aseptate and narrow aspergillosis. Continued on posaconazole. Day 7, resumed on ticagrelor without any aspirin. Day 9, re-extubated with intermittent BiPAP support. She had a prolonged hospital course, which lasted for 3 weeks, 3 to 4 weeks. She's still under follow-up, 10 months now. Antifungals were stopped after a month. She's doing fine. Her LVA function improved maximum up to 25 to 30%. She is on class 1 status now on all kind of anti-heart failure measures. RV is still down. Learning point from this space, never give up. Post-COVID, definitely keep a watch. Rotablation, the IF usage should not be contemplated in ACS situation. However, sometimes we should not leave any stone left unturned to salvage a patient. Multidisciplinary approach helps in managing such critical patients. Clearly, studies have shown IABP is not useful, but at that point of time, there was no time to escalate the support to Impella or ECMO. Rather, the patient can afford the therapy of Impella at that point of time. IVP definitely helped whatever it can do in that particular time. This is the learning point from this particular patient. Second one. Okay, I will stop with this, and sir told to have discussion on this first case. Any?
Dr. Bhagwat, would you like to make comments on?
Yeah, I mean, it was a complex situation. I think whatever best possible thing has been done. So I would not try to really dissect out this case. Basic point was to get him off the table.
Ashok?
No, I actually missed the first part of the case, which was the most important.
Okay.
So I'm not commenting on it.
Okay, sir.
All right. So, any comments from the audience on this case? Right. So this was such a long drawn battle, you know. So finally you were able to restore your patient back. Excellent. Let's.
We only see that your mucormycosis doesn't recur. Because I think the drug of choice is amphotericin.
Yeah, her kidneys function did not allow us to provide amphotericin, so we went with.
But if you use lysosomal amphotericin, that is safe.
Yeah, we discussed with the ID team, sir. If it is brain invasive, they suggested go for the potent antifungal. If it is not brain invasive, it's okay to proceed with posaconazole. The multidisciplinary approach was taken care at the point of time.
Okay,
So,
the second one, can we do it faster?
yes, sir. Someone has closed the PowerPoint already. Yeah, the second one is much more interesting actually. He's a 79-year-old guy
Only highlights.
presented with multiple comorbidities. To make the case simple and fast, multiple comorbidities evaluated outside for a peripheral gangrene in the right toe that extended all the way to the lower two-third of the left lower lip, lower two-third of the left lower lip. So he was planned for a BK amputation at that point of time elsewhere. One day before the BK amputation, he developed ACS. Angio done, showed a left main triple vessel disease. To summarize, elderly male with a severe PAD, critical limb ischemia, acute limb ischemia, has left main triple vessel disease. He was referred to us for further management. So, of course, surgically, he's not revascularable. Surgeon has declined at that point of time. His LV function was something around 40 to 45%, kind of mild moderate LV dysfunction. His right limb was okay. Left has got a significant lesion. The right, we went ahead salvaging this particular patient with MCS support. So this is the ECMO that is going through the right femoral line, temporary going through the left femoral vein, and guide through the left femoral artery. This is the coronary angiogram. I've taken only limited shot to salvage to save the time. It's clearly a densely calcified lesion. In this point of time, there's no use of imaging. We know it's densely calcified. We were more positive. We initially went ahead crossing the lesion with the run through, but fine cross could not grow. We directly wired the lesion with the rotawire. 1.5 burr could not negotiate. We downgraded. This is one situation where we may have to downgrade the burr. Extra stiff wire was not, stiff rotawire was not available at that point of time. So we downgraded the burr to 1.25. Still, it stopped after crossing the 50% of the lesion. At that point of time, we don't have anything else except about the rotablation and get the benefit of rotablation, whatever it has done. And the same burr was used to ablate circumflex and ramus intermedius. Later on, we proceeded with multiple small balloon dilatations. High pressure, ultra high pressure balloon was utilized. However, two ultra high pressure balloon actually ruptured inside the LAD. Then we utilized Wolverine to cut the left main circumflex, left main ramus intermedius, along with left main LAD lesions. With good amount of lesion preparation, we thought let's go for two-stent strategy. However, we could not pass a stent from the left main to circumflex. Hence, we changed the strategy from left main to ramus intermedius and left main to LAD. However, in this process, the stent got dislodged. Too much of calcium. It's a zotrolumos eluting stent. Whatever dislodgement happened in my practice has happened with this stent. I don't know about the experience of others. So this stent is staying inside the left main and the ramus, and the balloon is all the way inside the guide. You can easily appreciate in this picture. Now we utilize a guideliner, somehow manipulated and got the entire system back, and then rewired the system again. So we started with two-stent strategy, circumflex left main, circumflex LAD, downgraded to ramus intermedius left main, and now with this problem, we downgraded to single stent strategy. So sometimes we have to accept what we could do for the particular patient. During this time, ECMO was actually, since ECMO was already there, we did not had a significant hemodynamic issues. However, initially during the balloon rupture, the initial ECMO support was only 1.8 liters. Patient had a hypotension with it. Hence, we have to escalate the ECMO support to full 5 liters. That was the only time when the patient had hemodynamic decompromise. And then we stented the lesion from left main to LAD. This was done last year, February. Regular optimization stuffs was utilized to optimize the LAD and the left main stent. We were able to achieve a decent angiographic result, and the ECMO was slowly removed. ECMO was decannulated on table after coming down with the support slowly on table. 2 days later, mentored with the peripheral intervention, able to achieve a kind of a single vessel runoff, which was 0 initially. And then from BK amputation, 1 week later, he went for a grade 2 race amputation alone. He's walking on his own now. So what I learned from this particular case, MCS ECMO protector strategy in complex PCI definitely helps in selective patients. Stent dislodgement can happen in severely calcified lesions. How to retrieve it, mother and child technique, and maybe if at all I would have kept this strategy simple from the beginning. Maybe as for this elderly gentleman with severe comorbidities, starting the procedure from simple left main to LAD might have avoided the problem. IVL definitely would not have crossed, even Rota 1.25 could not do. A laser might have been an alternative choice in this particular situation. However, it was not available with us at that point of time. Again, managing this patient, we utilize the help of vasculars to get the ray amputation done. Sometimes, most of the time, multidisciplinary team approach helps. Thank you.
Thanks. 2 comments from our chairpersons, and I'll request Dr. Aliregi to please step forward.
One comment is that, after these are calcified arteries, calcium is the biggest enemy. And after you have done the rotablation, you dilate with the balloon. So I think at that stage, before stenting, we should do the IVUS or OCT. That is the value of imaging that time, because many times we think we have done rota and still there's a lot of calcium, and still there are problems of stent deployment, dislodgement, struggling with that. That's what happens usually. So that means the bed was not still prepared properly. So that's my thinking, that is the stage when IVUS is more useful.
Agreed.
So Nagendra, these are great cases. I was intrigued by your use of ECMO rather than impeller in such circumstances. ECMO is a fairly unphysiological support meant for truly situations where there are no pulses or there's no rhythm. It's certainly not a support that I recommend for supported PCI. I may on occasions recommend it for catastrophic shocks.
Okay. His pockets were constrained, sir.
Yeah.
That is the real reason.
So you may not have an impeller that time.
Thank you very
No,
much.
Impala was available, but he could not afford the same.
Thank you. Big hand. That's Dr. Hani Regi.